Welcome to The Explainer. We're jumping right into the highly specialized and frankly fascinating world of repairing the delicate area around the eye after skin cancer removal.
Think about this for a second. An eyelid must move, close, protect the eye, and help manage tears. A wound that is merely covered is not necessarily functionally restored. That highlights the incredible complexity of this area, and this explainer is based on the article by Thomas L. H. Hocker, MD, MPhil. So, here's our roadmap for today. We'll be covering why eyelids are unique, how cancer clearance comes first, why anatomy guides the plan, options for selected wounds, when specialists join in, and finally, recovery and care plans. All right, Section 1, why eyelids are unique. We really need to understand why the eyelid is just fundamentally different from skin anywhere else on the body.
You see, the eyelid isn't just a static patch of skin, right? It has incredibly dynamic, vital jobs to do. The eyelids have to spread the tear film and direct tears toward a drainage system. A successful reconstruction absolutely must actively protect eyelid position, closure, blinking, tear drainage, and the overall surface of the eye. If a repair leaves the lid pulled down, or maybe turned outward or inward or unstable, it can cause severe exposure, irritation, or even direct injury to the eye itself. So it's all about restoring function, not just simply covering a defect.
Moving on to Section 2, cancer clearance comes first. This establishes what is basically the golden rule of all periocular reconstruction. The definitive reconstructive plan follows a very specific sequence. Step 1 is you clear the cancer and inspect the final wound. Step 2 is you choose the definitive repair. Now, while your surgical team can absolutely discuss probable repairs with you beforehand, the definitive reconstructive plan is chosen only after margin clearance reveals the true wound. Why? Because techniques like Mohs surgery use a microscopic map to remove tissue only where cancer remains, so the exact number of layers or the direction of hidden tumor extension simply can't always be predicted from the surface. You have to see what you're working with first.
And that brings us right to Section 3, Anatomy Guides the Plan. Let's look at how the specific structural anatomy of the final defect actually dictates the surgical approach.
Clinicians basically view the architecture of the eyelid in two distinct layers. You've got the outer layer, which includes the skin and muscle, and then you have the inner layer, which provides that firm support and the lining that directly faces the eye. This distinction is huge and completely changes the plan. A shallow, partial thickness wound involving only that outer layer requires a totally different reconstructive plan than a full thickness wound that removes both layers.
So, keeping those layers in mind, what structural features actually determine the final repair? Think about the specific physical variables a surgeon has to evaluate once that cancer is fully cleared.
Well, here's exactly what they're looking at. First, location matters immensely. Are we talking about the upper lid, lower lid, inner corner, outer corner, or the brow? They're also assessing eyelid margin stability, because that margin has to rest in the correct position against the eye. They'll check if the wound is partial or full thickness and whether the tear ducts or canthal support structures are involved. And finally, they look at tension from nearby skin, like the cheek, which can pull and actually change the eyelid position during healing. In this area, we're talking about a space where even a few millimeters can completely change the reconstructive problem.
Okay, Section 4. Options for selected wounds. The crucial point we need to remember here is that we are looking at a menu of individualized options for selected wounds rather than automatic assignments.
There are so many varied, individualized approaches to repair. For instance, second intention or natural healing lets the wound fill without stitches, which fits selected shallow, well-supported wounds. Direct closure brings the edges together in a planned line for selected wounds with mobile tissue. Then you have skin grafts, which cover the wound with skin borrowed from another site for surface replacement, while a local flap moves nearby skin along with its blood supply when tissue match or contour is really useful. For larger or full-thickness defects, a staged repair might be used to rebuild missing layers in steps, and specialist collaboration adds crucial oculoplastic expertise for tear drainage or major margin defects. Remember, no single option is automatically superior. The exact same technique can be brilliant for one wound and completely wrong for another.
And the evidence strongly backs up this highly individualized approach. Consider a systematic review of 53 periorbital reconstruction studies. That review analyzed 3,678 total repairs using a bunch of different methods. Yet out of all of those, only 3 studies used a defined grading system, objective measurements, or an independent cosmetic review. What does that tell us? Well, it essentially proves that the evidence supports individualized selection tailored to a specific patient's anatomy, rather than some universal appearance ranking among all repairs.
To give you an idea of how much context matters, let's look closer at second intention or natural healing. In a 39 defect cohort, larger wounds actually had poorer results with second intention healing. We're highlighting the specific cohort size to give you some really useful context. It shows us that natural healing is definitely a viable option, but it is best reserved for carefully selected wounds.
Let's explore Section 5, when specialists join in. This covers the specific scenarios where adding a coordinated specialist, like an oculoplastic surgeon, adds vital capability.
A fellowship-trained Mohs surgeon repairs many selected periocular wounds themselves, but collaboration is especially useful when the wound involves substantial eyelid margin involvement, or maybe both the outer and inner eyelid layers. It's also incredibly helpful if the wound involves the punctum, canaculus, or other tear drainage anatomy, the canthal support structures, or deeper orbital tissue. Now, these are valid, strategic reasons to match the surgical team to the anatomy. But it's very important to understand that none of these findings automatically mean that every wound near the eye requires an outside referral.
That leads perfectly to this point. Referral reflects anatomy and capability. It does not automatically mean the cancer is biologically worse. If your surgeon recommends an oculoplastic specialist, be reassured. A referral is simply a strategic tool to protect your vision and function. It is absolutely not a failure of the initial surgery.
Finally, Section 6. Recovery and care plans. Let's discuss what you should really expect during the recovery process.
Perhaps the single most important piece of practical advice we can give today is this. You absolutely must follow your treating team's repair-specific instructions rather than relying on a generic online checklist. Because there are so many individual variations in anatomy and repair techniques, generic wound care instructions or warning sign lists simply do not apply here. You need to get your detailed recovery guidance and your exact contact plan directly from the team that actually performed your eyelid repair.
To help manage expectations, let's look at the general timeline of healing. During early healing, expect swelling, bruising, and scar firmness. The area around your eye can look quite different early on, and that's normal. However, as we move months later into the healing process, scar appearance and facial quality of life measures can continue to improve for many months before you ever reach the final, mature result.
So hold on to this grounding truth. An early result is not the final result, but no surgeon can promise an invisible scar. While the reconstructive team works meticulously to protect the eye and restore missing function, there are simply no guarantees of a perfect cosmetic outcome. Setting realistic expectations right from the start is absolutely key. I want to conclude by leaving you with a vital question to take directly to your reconstructive team. Which options are reasonable for my specific wound, and what is the trade-off of each? Asking this ensures you aren't just a passenger in this process, but an active participant in your own recovery. Thanks for joining us for this explainer, and stay curious.